Gynecomastia is the enlargement of the male breast as a result of hyperplasia of the glandular tissue to a diameter greater than 2 centimeter. It is common, present in up to 1/3 of the male less than 30 years and up to 50% of the male greater than 45 years. So there are few pathophysiological mechanisms which are involved. Testosterone replacement leads to uh, increased aromatase activity, which then converts testosterone to estrogen, uh, which leads to increased estrogen action on the breast tissue and resultant gynecomastia. Likewise, if there is increased LH or increased level of HCG, then again, both of these hormones would lead to increased aromatase activity, increased conversion of testosterone to estrogen, with resultant increase in the estrogen. Likewise, if there is if there is decreased testosterone, which can also lead to gynecomastia, increased estrogen because of any cause can also lead to gynecomastia. With increased level of sex hormone bind with globulin, there would be more binding of the testosterone. Uh, as a result, there would be more estrogen as compared to testosterone, which then leads to gynecomastia. So there are certain differential diagnosis and causes of gynecomastia. It could be physiological, which can be present in the neonatal period. In puberty, up to 50% of the boys develop transient gynecomastia. Idiopathic, which is present in 25% of all cases. Then there are drugs, possibly mechanisms including estrogen-containing androgen receptor blocker and inhibiting androgen production. So whenever there is increased estrogen or decreased androgen activity, can lead to gynecomastia. These medications include estrogens, anti-androgens, and testosterone, spironolactone, AC inhibitors, calcium antagonist, and digoxin. So among the antihypertensive, AC inhibitors and calcium antagonists are very important cause of gynecomastia. Alcohol, among the recreational drugs, alcohol, marijuana, heroin, and methadone. So methadone, marijuana, alcohol, and heroin, these are the common drugs for recreation purposes. Likewise, antihistamine including the cimetidine, ketoconazole, metronidazole, anti-TB, tricyclic antidepressants, dopamine antagonist opioids, benzodiazepines. These can all lead to gynecomastia. Antiretroviral drugs and imatinib, which is used in the chronic myeloid leukemia, can also cause gynecomastia. Then if there is hypogonadism, which then leads to decreased activity of testosterone, and this could be primary or secondary. Both the primary and secondary can cause hypogonadism, gynecomastia. Then there are certain tumors like estrogen or androgen producing testicular or adrenal tumors, human chorionic gonadotropin producing tumors, usually the testicular ones, including the germinoma, occasionally ectopic from the lungs. Aromatase producing testicular or hepatic tumors. Then there are endocrine causes like thyrotoxicosis, Cushing, acromegaly, and androgen insensitivity syndrome. Systemic illness can also lead to gynecomastia, like the liver cirrhosis, renal failure, HIV infection, and malnutrition. So overall, the differential diagnosis can be summarized as the physiological, drugs, hypogonadism, tumors, endocrine disorders, and systemic illness. So the evaluation of gynecomastia should be, you should ask about the duration and progression of gynecomastia. Further investigation is warranted if there is rapidly enlarging gynecomastia, recent onset gynecomastia in a lean post-pubertal male, painful gynecomastia. So recent onset, painful, and rapidly progressive. These are the alarming signs. We should exclude the underlying cause like the testicular cancer. If we should see for the signs of hypogonadism like reduced libido, erectile dysfunction, and the symptoms of systemic disease like hepatic, renal, and endocrine disorder, drug history, including the recreational drugs and alcohol, are very important. While doing the physical examination, we should check the breast and measure the glandular tissue diameter. Gynecomastia is confirmed if it is greater than 2 centimeter. If it is greater than 5 centimeter, hard and irregular, we should investigate to exclude the breast cancer. And at the same time, we should look for the galactorrhea. We should palpate the testes for the possible tumor and for the possible atrophy. Secondary sexual characters should be assessed for the possible hypogonadism, and we should see if there is any systemic disease like chronic liver or renal disease, cytotoxicosis, Cushing syndrome. Investigations include baseline investigation and additional investigations. Baseline investigations include serum testosterone if to see if there is any to see baseline investigation to see hypogonadism, which includes LH and FSH level, serum testosterone level, because in hypogonadism, the testosterone would be less and the LH and FSH would be low or high depending on the primary or secondary hypogonadism. Likewise, estradiol would be increased in cases of any estrogen producing tumor, and prolactin and sex hormone binding globulin are also measured to see if there is any problem like prolactinoma. A sex hormone SHBG is important as increased level of sex hormone binding globulin will lead to um, abnormalities in the measurement. HCG, because choriocarcinoma is one of the differential, and liver function test. These are the most common tests which should be performed. Likewise, additional tests include ultrasound tumor. If there is a suspicion of the ultrasound, should check the raised estradiol, HCG, and testicular ultrasound. So the testicular tumor, raised HCG, raised estradiol, HCG, and testicular ultrasound. If the adrenal tumor is suspected, markedly raised estradiol, dehydroappendage, DHEA sulfate, abdominal CT or MRI scan. If breast malignancy is suspected, mammography and FNA. If lung cancer is suspected, you should check for the raised HCG and chest radiograph. Another investigation would depend on the cause. So to summarize, we should check the HCG, LH, testosterone, estradiol, and TSH. If everything is normal, then we should be assured. However, if the TSH is low, then it can be because of the thyrotoxicosis. It's because of the thyrotoxicosis. If the LH is increased and testosterone is less, then it is most likely hypogonadism. If both the LH and testosterone are low, then it could be secondary hypogonadism, or prolactinoma can also present with decreased LH and decreased testosterone. So prolactinoma is one of the important differential. If the LH is increased and there is increased LH and testosterone, then it is because of the androgen resistance, increased HCGR, increased E2. We should get the testicular ultrasound. If there is any abnormality, then it's most likely testicular tumor. If it is normal, then we should get the abdominal CT imaging to rule out extragonadal estradiol or HC secreting tumors. So the management includes treat the underlying cause when it's present, withdraw any offending drugs where possible, Reassurance in the majority of the idiopathic causes often resolves spontaneously. Treatment may be required for cosmetic reasons and to alleviate the pain and tenderness. Drug treatment only partially effective may be of benefit in treating gynecomastia of the recent onset. The commonly used medications include tamoxifen, 10 to 30 mg per daily. It has got the anti-estrogenic effects, particularly effective in reducing the pain and swelling if it is used in gynecomastia of the recent onset. A 3 months trial before referral for surgery should be considered. Then clomiphene, it is used to 50 to 100 mg per day. It's also anti-estrogenic, may be effective in reducing the breast size in the pubertal gynecomastia. So clomiphene is for the reduction of the size and pubertal gynecomastia. Then danazol, it's non-aromatizable androgen, may also reduce the breast size in adults. It is for the adults, and its use is limited by the side effects, particularly weight gain and acne. So it's non-aromatizable androgen and used for the reduction of the gynecomastia in adults. Testosterone aromatase inhibitor. It's effective in reducing pubertal gynecomastia, and however, tamoxifen appears to be more effective and better tolerated. Anastrozole, another aromatase inhibitor, clinical trials have failed to show any beneficial effect on gynecomastia. So overall, if we see, there are two anti-estrogenic drugs. One is tamoxifen and clomiphene, and the other is clomiphene. Tamoxifen is more widely used because it reduces the pain, swelling, and however, there are few aromatase inhibitor. There are two aromatase inhibitor. One is testosterone, and the other is anastrozole. And one is aromatizable androgen, which is danazol, and it's also used to reduce the breast size in adults.